this opportunity. My topic is follow-up of early lung cancer. I have divided this topic into two subdivisions: follow-up and discussion about imaging modalities and what are the chronic complications and how to tackle them. This discussion is not intended for patients who are active treatment with any kind of adjuvant treatment maintenance. It is not intended for patients who are diagnosed to have advanced lung cancer. And this also the target population is not about patients who are symptomatic and you are suspecting recurrence. It is just for follow-up patients. Also, imaging specifically in follow-up should not be advised to patients who are not fit or who will be not willing for further oncological treatment in case a recurrence is detected. Now coming to main the issue in follow-up is imaging. As of now, there is no clear evidence demonstrating that there is a survival benefit of imaging regularly of these patients. Rationale of imaging in the follow-up was to detect recurrent disease, which gives us additional time for planning of treatment and choosing the right modality. Detecting second lung primary and other smoking-related malignancies like head and neck, esophagus, or all the secondary malignancies related to this smoking and tobacco use. Also, whether the early intervention could increase in survival if curative and improve in quality of life. So coming to most of this talk I have taken from the JCO publication of ESCO guidelines of follow-up of these patients. So patient should undergo surveillance imaging for recurrence every 6 months for first 2 years after the completion of treatment. Here the evidence quality is low and strength of recommendation is moderate. Patient should also undergo surveillance imaging for detection of new primary lung cancers annually after the first 2 years. So for first 2 years, every 6 months imaging. After 2 years, it is annual. This is for NSCLC. For small cell lung cancer limited stage, there is not much of data available. Clinical evaluation has to be done every 3 months with careful assessment of signs and symptoms of recurrence, and symptom-directed imaging is recommended. Also, why we need to do imaging here is just to same issue ki although generally the relapse in small cell lung cancer is florid, it might give early potential time to recruit in some clinical trial or use some investigational modality. Also for participation, patient reassurance and screening of some new non-small cell lung cancers, which are uncommon but have known to occur in this population subgroup. To summarize what I said initially regarding the overall survival data, this is a French publication, IFCT 0302 trial, which is presented but yet not fully published, which randomized around 1700 patients with resected stage 1, 2, and 3 NSCLC patients to clinical examination plus chest X-ray every 6 months for 2 years, and then annually for up to 5 years, or clinical examination, chest X-ray, thoracoabdominal CT with bronchoscopy at same interval. Here, 68% of patients had stage 1, 14% at stage 2, and 18% at stage 3 cancer. At median follow-up of 8.7 years, no OS benefit was identified in patient who had undergone CT versus patient who had undergone chest X-ray on the follow-up. The full publication is yet awaited. So this was the first randomized trial of a resected NSCLC patient, which did not show any evidence of improvement in survival with CT screening. Clinician should use diagnostic CT that includes the adrenal with contrast preferred or without contrast when conducting surveillance for recurrence during first 2 years post-treatment. And clinicians should use low-dose screening CT scan after 2 years for detecting new lung primaries. Clinicians should not use FDG PET CT as a surveillance tool. After 2 years, basically the goal of surveillance switches from detection of recurrence to detection of second primaries. CECT, they yield better accuracy and they reduce the inter-reader variability. However, this reduction is only for hilar lymph nodes. Recognition of mediastinal lymph nodes is more or less not affected. And in study where FDG PET CT was used for surveillance versus standard CT plus bone scintigraphy and MRI, there is no improvement in sensitivity and specificity of FDG PET. Also, the FDG PET, the exposure of radiation is around 32 millisieverts versus 3 to 7 millisieverts in diagnostic CT chest versus 2 millisieverts in the low dose CT scanning, which we are recommending after 2 years. Also, there is issue of cost. PET CT is more costly as compared to a diagnostic CT, which is more costly as compared to low dose CT scan. Also, we do not know what is the positive predictive value and negative predictive value in the Indian population due to high prevalence of tuberculosis and granulomatous diseases. Now, as I said previously, surveillance can be, imaging can be omitted in patients who are clinically unstable or not suitable for any further treatment or not willing for any oncological directed treatment. And age is not any preclusion for surveillance imaging in these patients. Biological age matters rather than chronological age. Also, clinicians should not use circulating biomarkers as of now as a surveillance strategy for detection of recurrence in patients who had undergone curative intent treatment for stage 1 to 3 NSCC or small cell lung cancer. Some people do CA in follow-up, but it has not yet to show any difference in the survival of the CA monitoring. Also, there are concerns regarding false positivity due to COPD and smoking. There are 2 publications for cell-free DNA. One is by Abosh et al., other is by Chaudhary et al. Here, what they did, they screened this patient for cfDNA for looking relapse. 93% cases and 72% cases were detected early before even imaging. In the first publication, it was 2 months, and later publication, it was 5 months. So there was some early detection, but we do not know whether it will really translate into overall survival benefit. For patient for stage 1 to 3 NSCLC, clinicians should not use routine brain MRI for follow-up. In patients of small lung cancer who are treated with PCI or not treated with PSI, every 3 monthly follow-up with MRI brain is recommended. So there is no benefit of doing MRI in non-small cell lung cancers for a routine follow-up. In small cell lung cancer, it has to be done because it gives us plan for planning definitive RT even post WBCI use of IFRT, the directed radiation therapy for symptomatic care. Now coming to the second part, chronic complication and late effects. Basically, these are sequelae of surgery, radiation, chemotherapy, and immunotherapy or immunotherapy. Other aspects include psycho-socio-economic aspect of treatment and follow-up. Now, 80% of these patients on follow-up have some kind of physical symptom. 30% of them are clinically significant. Fatigue is most common symptom in these patients on follow-up. Some studies report up to 90%, and it is linked to depression, anxiety, chronic pain, psychological distress, dyspnea, and sleep disturbances. Dyspnea is also second most common symptom here, with studies quoting roughly 55 to 87% in all stage of lung cancer. Chronic pain occurs in around 50% of lung cancer survivors, specifically after a thoracotomy. 50% of these patients, they report inadequate pain control, and nearly 40% of these patients have some kind of chronic pain symptom and syndrome. Patients who have received chemotherapy, they generally develop long-term peripheral neuropathy, and some of them do develop autonomic neuropathy, leading to changes into blood pressure, causing postural hypotension and arrhythmias. There are chances of metabolic syndrome in terms of dyslipidemia, obesity, hypertension, and increased risk of stroke and ischemic heart diseases. And lobectomies and bilobectomies have been associated with significant decline in sleep, mental function, sexual activity, and overall health-related quality of life, even years after post-resection. Psychological distress, it occur up to 80% of lung cancer survivors. It is 3 times more common than observed in survivors of any other type of cancer. There is generalized fear, specific fear for recurrence, sadness, worry, uncertainty, stress, poor quality of sleep, lack of concentration, depression, anxiety, suicidal ideation, and survivor's guilt. Clinician treating a survivor of lung cancer might consider routine screening for this symptoms using this scales PHQ, GAD, and distress thermometer for psychological distress. Also, cognitive impairment occurs due to all these above mentioned factors, and there is subjective difficulties in some of patients with attention, concentration, and short-term memory. Sexual dysfunction, this is also very common in most of the patient, but is very often untalked about. 60% of cancer survivors report having long-term sexual dysfunction, and fewer than 25% of them seek help. This is associated with shortness of breath, fatigue, emotional distress. There are also issues regarding sexual desire, erectile dysfunction, orgasm, frequency of sexual activity, body image, and communication about sex. Coming to addressing the high-risk behavior in follow-up, persistent tobacco use, it is more likely to, these patients who continue to use tobacco, they are more likely to develop second cancer. They have higher rates of cancer and non-cancer related mortality. After surgical resection with curative intent, second tumors are up to 2.3 times more common, and recurrent tumors are 1.9 times more common in patients who continue to smoke. Overall mortality in this patient is almost 3 times higher. The drug metabolism is affected due to enzyme induction, and quality of life is also compromised who patient who continue to use tobacco post the treatment. There are very few studies and data regarding diet, but it is generally known that high fiber, good vegetable and fruit diet reduces the chances of lung overall all cancers. It is very difficult to assess because these are ecological studies and there are a lot of confounding factors. Similarly, weight, but it is limited evidence suggests that higher baseline weight and weight gain during treatment are correlated with improved outcomes in lung cancer. Physical activity leads to improvement in quality of life in all the 5 major domains, that is mental, physical, emotional, social, and spiritual, and it is often associated with decrease in pain and cognitive impairment and psychological issues. Vaccination is very important. It is often overlooked, and even this was not given in guidelines. I think it is very relevant in this COVID era. It might decrease mortality, morbidity related, specifically related to respiratory predominant diseases like COVID, pneumococcal infections, influenza infection. However, here the issue is we do not know what is the immunogenicity, immune recognition, and immune reconstitution post-vaccination. There are other multiple challenges to family life of these patients. For example, whether to procure, whether to go for next child, how to complete family planning, challenges to caregiver burnout. Also, there are challenges in coordination. A lot of the peripheral hospitals, they do not have dedicated departments for taking care, like social services or psychiatry department, all those departments. So take home or clinic message: routine MRI brain scans, except in case of small cell lung cancer. Cell-free DNA, PET CT scan is not recommended. Aggressive imaging and follow-up is yet to show any benefit in terms of survival. Quality of life, symptomatic care, rehabilitation, and vaccination should not be overlooked in overzealous pursuit to investigate recurrence. Thank you. If there are any questions, thank you.